Hello, future doctors. How are you all? Welcome back to MedSteps Internal Medicine Series, Episode 4. So, in our previous episode, we discussed about like Episode 1, acute pericarditis. In Episode 2, we learned about valvular heart disease. In Episode 3, atrial fibrillation. So, right now, we are in Episode 4, that is very life-threatening condition, that is infective endocarditis. So this infective endocarditis is an infection of the inner lining of the heart, especially the heart valves, leading to formation of vegetations that can destroy valves and causes systemic complications. So a patient may be present with fever, unknown origin, a new heart murmur, fatigue and weight loss and embolic complications. But diagnosing infective endocarditis requires a combination of clinical suspicion and blood culture and echocardiography findings. So in today's episode, we will understand the definition pathophysiology of infective endocarditis and what are the organisms and risk factors and clinical features and clinical signs. And we have one criteria we called Jukes criteria for diagnosing infective endocarditis and blood culture interpretation, echocardiography, and what are the antibiotics we have to give and what are the complications and what are the things we have to prevent strategies. Everything we are going to discuss in this episode. So this topic is extremely important for clinical practice and high yield, and if you're doing internal medicine or department or cardiology department, okay, and if you're preparing for a yield exams like FMGE, NEET PG, USMLE, okay, for ASCII settings, if you are preparing means this is the very important and high yield topic. So without time waste, let's start. Infective endocarditis means it's like infection involving the endocardial surface of the heart. It mainly affects the heart valves and endocardial surfaces and prosthetic valves. So if you're seeing definition here, this is the main definition. Infective endocarditis is an infection of the endocardium of the heart, usually involves the cardiac valves caused by microorganisms producing vegetations. Okay, so we have some acute infection, but more commonly runs an insidious course which is known as subacute endocarditis. So vegetations consists, whenever I'm mentioning about vegetation, so what it means? Vegetation means it consists of microorganisms, platelets, fibrin and inflammatory cells. Okay, so this infective endocarditis, we have total 3 different types. Okay, the first one you can see here, the first one will be like NVE, means native valve endocarditis because of infection of normal or proper native valves. Second one you can see PVE, means prosthetic valve endocarditis. It occurs in patients with artificial valves early, less than 1 year after surgery, or in late cases 1 year after surgery. Okay, so third type will be like you can see right-sided endocarditis. Right-sided endocarditis means is common in intravenous drug users, usually affects tricuspid valve. Okay, tricuspid valve, it mostly affects because of drug abuse. Okay, so next we can see here, that is the main causes. Here causative main causes will be like in infective endocarditis, that is the most common organisms will cause infective endocarditis. That is first one you can see here, that is Staphylococcus aureus. So this Staphylococcus aureus, it is the most common cause overall. So it's like rapid progression and it can infect normal valves. Okay, next you can see that is streptococci. It's most common virulence streptococci. So it's usually abnormal valves and slow progression. Okay, next you can see here, whenever patient getting the Staphylococcus aureus, we have to suspect acute infective endocarditis, or maybe patient have history of intravenous drug users. Next, in virulence streptococci is the most common. If any patient recently did any dental procedures or damaged valves, this is the main organism will cause. Next we can see that is coagulase negative staphylococci. That is the main thing, main organism. If any person did any prosthetic valve setting, the patient will get this infection because of this coagulase negative staphylococcus. Next we can see that is another one, Pseudomonas aeruginosa. This is the one of the organism can cause infective endocarditis. Next we can see Hasek organism, Haemophilus saprophyticus, Aggregatibacter saprophyticus, Cardiobacterium saprophyticus, Echinella corrodens, and Kingella saprophyticus. So this is the organisms we call Hasek organisms. The culture will be negative in infective endocarditis. Next we can see Enterococci. Enterococci mostly because of urinary or GI source of infection. Causative organisms infections can cause. Next, fungi also can cause infective endocarditis. Okay, so next we can see some risk factors of infective endocarditis. You can see here that is first one. These risk factors we can divide into two different types of risk factors. One is cardiac risk factors, second one non-cardiac risk factors. So first I'm going to discuss about cardiac risk factors. In cardiac risk factors we can see previous infective endocarditis or prosthetic heart valves or valvular heart diseases, okay, with stenosis or regurgitation, okay, and or rheumatic heart diseases or congenital heart diseases. So these are the main cardiac risk factors. Okay, so next we can see non-cardiac. And in cardiac, hypertrophic cardiomyopathy and recreational drug abuse, this is non-cardiac. And invasive vascular procedures, this is cardiac. So in non-cardiac you can see here that is intravenous drug use or poor dental hygiene, indwelling catheters or immunosuppression or hemodialysis. These are the main risk factors of infective endocarditis, that is cardiac and non-cardiac risk factors. Okay, so next we can see here that is pathophysiology. In pathophysiology, how we can see this infective endocarditis will affect. So we have to understand some things. So first of all, the valve will become injury. Okay, so the valve surface of the heart that will get endothelial damage, injury will happen. So secondary to turbulent blood flow because of endothelial damage, because of the thing, because of backflow of the blood like regurgitation, we can see this type of we can see this type of valve injury, valve problem. Next, because of the thing we can see endothelial damage, then after the platelets will aggravate, then we can see mass of fibrin will form like platelets and infectious organisms form vegetations. Okay, so along with that edges of the valve, you can see here, this is the image, you can see here this is a marking. So this type of fibrin deposition you can see. Then after the formation of sterile vegetation. So I already told vegetation means what? Vegetation means microorganisms or platelets, fibrin, inflammatory cells. We call that is vegetation. So these vegetations will form. These vegetations will form in that valve. Then after we can see transient bacteremia. Then after microorganisms will attach to the vegetation. Then after we can see infective vegetation formation. Then after valve will become destruction. Then after patient will get the most commonly affected decreasing order frequency like mitral valve, aortic valve. Then after 3 combined mitral and aortic valve and 4 tricuspid, and more common in intravenous drug abusers, and pulmonary valve will be like very rare. Okay, so the valve will become destruction. Then after we can say regurgitation. Then at last the patient will get heart failure. Okay, so this is infective endocarditis pathophysiology. Next we can see here some clinical features. In clinical features we can divide into 2 different parts. One is acute infective endocarditis and subacute endocarditis. So in acute endocarditis, the features will be like very simple, like high fever, toxic appearance, and rapid valve destruction, and usually Staphylococcus aureus. Next we can see subacute infective endocarditis, like features will be like low grade fever, fatigue, weight loss, weeks to months progression, and usually we can see viridans streptococci will cause subacute infective endocarditis. Next, in clinical features, we already mentioned that fever, rigors, night sweats, malaise, weight loss of appetite, fatigue, flu-like illness, and joint pains we can see in infective endocarditis. So next, in signs, while doing physical examination, you can see this type of signs like fever, heart murmurs, you can listen. Okay. So in heart murmurs, you can see like new murmur due to valve destruction. You can mostly get regurgitation. It may be mitral regurgitation or aortic regurgitation. Then it will lead to heart failure because of a valve dysfunction. Okay. Next we can see some petechia and splinter hemorrhage. Splinter hemorrhage means you can see here, you can see this type of splinter hemorrhage you can see. Okay, so you can see splinter hemorrhage. Then after you can see another one, ossular nodes. I don't have proper picture. Next, Janeway lesions. Janeway lesions means it's like painless erythematous lesions we can see in palms and soles. The main cause will be like septic emboli. Okay. Next we can see that is ossular nodes. In ossular nodes we can see like that is ossular nodes will be like painful nodules we can see in finger and toe pads. It will the main ossular nodes will cause because of immune complex deposition. Other classic symptoms we can see that is splinter hemorrhage, that is linear nail bed hemorrhage. Next one, Roth spots. Roth spots means you can see retinal hemorrhage. This type of hemorrhage you can see with pale center. Next we can see clubbing. Clubbing means is seen in chronic diseases. This type of clubbing picture you can see in physical examination. If you are telling to keep that index finger together means we can see the clubbing marker. Okay. Next, arthritis, splenomegaly, and meningism. This is the most common signs we can see in infective endocarditis. Okay. So next, we can see some complications in infective endocarditis. These are the main complications like myocardial infection. The cardiac complications we can see like myocardial infection, pericarditis, cardiac arrhythmia, and heart valve insufficiency, congestive cardiac failure. Okay, and perivalvular abscess also we can see in cardiac complications. Okay, next we can see some embolic complications like left-sided infective endocarditis because of vegetation. We can see systemic emboli, and it can lead to stroke, and splenic abscess or mesenteric infection, or splenic infection, or renal infection. Okay, next you can see right-sided infective endocarditis complications. You can see tricuspid valve involvement, emboli go to lungs, then after septic pulmonary emboli. Okay, and the main features of septic pulmonary emboli, you can see cough, chest pain, pulmonary infiltrates, and these are the things. Then after arthritis, myositis, glomerulonephritis, acute kidney injury, okay, sinus of valsalva aneurysm, and aortic root myocardial abscess. So these are the things you can see. Next, investigation. What are the things we have to mostly focus on investigation? First of all, blood test. In blood test, full blood count like reduced hemoglobin and increased the white cell count. Okay, and in CBC it may show leukocytosis and anemia, and we can see some inflammatory markers will increase like CRP and ESR will increase. Next we can do like urinary analysis and culture for checking possible acute kidney injury and kidney function test, and serum immunoglobulin will increase and complement levels will reduce. So next we can do that is blood culture. Blood culture is very important test. It's like 3 sets taken at different sites of different times. So why blood culture? Obtained before antibiotics, take multiple sets of different sites, and this is very important to diagnostic importance for positive cultures for major Dukes criteria. So that's why this blood culture is very important. Next, urinary analysis for microscopic hematuria. Next, ECG, 10% of patients will develop conduction defects, And chest x-ray, we can see heart failure or evidence of septic embolism in right-sided endocarditis. Next, we can do echo. Echo also transthoracic echo we have to do, that is the initial test. Okay, then after we have to go with transesophageal echo, that is more sensitive for prosthetic valves and small vegetations and abscess. Okay, so within 24 hours we have to do. Okay, next serology, we have to do echocardiography to show the main findings like vegetations, and it will show valve destruction and abscess and regurgitation and this type of things. Next, we can see serology. That serology is useful if unusual organisms are suspected. Example like Coxella saprophyticus and Bartonella saprophyticus or Legionella saprophyticus. Okay, so MRI, we can do that. MRI is like nuclear imaging and multi-slice CT coronary angiography to like imaging modalities which may be used. So next, the main thing we have, that is criteria, that is Jukes criteria. Okay, this is the main Jukes criteria will help to diagnose infective endocarditis. So this Jukes criteria, it's based on two main criteria, and is major criteria and minor criteria. In major criteria, we can see positive blood culture and we can see evidence of endocardial involvement. So it will help. Why this thing important means, the positive blood culture, typically microorganisms from two separate blood cultures will be like positive. Okay, and the evidence of endocardial will help to find out the vegetation, abscess and new valve regurgitation like oscillating intracardiac mass and valve supporting structures or abscess, new partial dehiscence of prosthetic valve or new valvular regurgitation. Okay, next we can see that is minor criteria. In minor criteria, we can see here that is predisposing heart conditions like intravenous drug use. Next we can see fever like greater than 38 degrees Celsius. Yeah, we can see Jukes criteria. In Jukes criteria, we are seeing now evidence minor criteria. In minor criteria, we can see here that is predisposing heart conditions like intravenous drug use and fever greater than 38 degrees and vascular phenomenon like major arterial emboli and septic pulmonary infarcts or mycotic aneurysm, intracranial hemorrhage and conjunctival hemorrhage and JNV lesions we can see. So it will, everything will comes in minor criteria. Next one, we have another one, that is immunological phenomenon like glomerulonephritis like osler nodes, Roth spots and rheumatoid factors. The positive blood culture we can see that is not meeting major criteria, and we can go with positive blood culture not meeting major criteria and echo. Echo will consist with infective endocarditis but not meeting major criteria. Okay, so in diagnosis, the definite infective endocarditis must be like two major criteria, or you have to go with one major criteria plus 3 minor criteria, or you can go with 5 minor criteria. So if patient have 2 major criteria or 1 major criteria with the 3 minor criteria and 5 minor criteria, then you have to suspect patient have infective endocarditis. Okay, next you can see here that is management. In management, the main thing is we have to focus on identifying organism, and we have to start appropriate antibiotics, and we have to monitor complications, and we have to consider surgery when indicated. So next we can start antibiotics. In that antibiotics, the main treatment is required, that is intravenous antibiotics and prolonged duration, and usually 4 to 6 weeks we have to give. Okay, 2 to 4 weeks we have to give empirical antibiotics therapy. So the choice depends on organism, valve type and sensitivity pattern. Okay, so In antibiotics, thing the main antibiotics we can see here, that is first one, vancomycin. The vancomycin is the class of drug will be like glycopeptide antibiotic. That's like weight based, we have to use dose, and the route will be like intravenous. The frequency usually every 12 hours we have to use. The duration will be like 4 to 6 weeks. The indications we are using for MRSA and resistant organisms, and we have to focus on renal function and other levels. So next we can see, that is ceftriaxone. In ceftriaxone will be like third generation cephalosporins. The dose will be like 2 grams. The route will be like intravenous, and frequency will be like once daily we have to use. The duration will be like usually 4 weeks, depends on regimen. And the indications will be like ceftriaxone we have to use if you are suspecting viridans streptococci. In blood culture the viridans streptococci came, then you can use ceftriaxone. Ceftriaxone is good outpatient option in selected cases. Next we can go with another one, that is gentamicin. Gentamicin is class of drug is aminoglycoside, and we have to use dosage with based on weight, and we can give intravenous once daily, adjusted based on dosing. And the duration will be like the duration will be like short course in selected cases. The indications will be like we can see synergy in selected infective endocarditis. The important notes will be in nephrotoxicity risk. Next we can see, that is nafcillin and oxacillin. Nafcillin and oxacillin, we can see, that is class of drug will be like anti-staphylococcal penicillin. The dose we can see like 2 grams of dose, and the route will be like intravenous, and frequency every 4 hours. The duration will be like 4 to 6 weeks, and the indications will be like MSSA, infective endocarditis. The important note will be like monitor allergy and liver function. Okay, so next we can see, that is penicillin G. So the penicillin G, the class of drug will be like penicillin antibiotics. The dose will be like dose adjusted based on patient severity, and route will be like we have to give intravenous and multiple daily doses. For duration will be like 4 weeks selected cases. If the indication will be like streptococcal infective endocarditis, we have to use penicillin G. The important will be like sensitivity will guide us. Okay, so antibiotic choice must be guided by blood culture. Okay, so blood culture will guide us which antibiotic we have to give, and local antimicrobial guidance. So we have some surgical indications also. When surgery is needed means if patient have heart failure like due to valve destruction, an uncontrolled infection, or persistent bacteremia or abscess formation, and we can see prevention of embolism like large mobile vegetations and recurrent embolic events. Okay, so in prevention we have to start in surgery we have to do valve repair or valve replacement. In prevention, we can start antibiotic prophylaxis. It's recommended only for high-risk patients undergoing certain dental procedures like high-risk groups, prosthetic heart valves, previous infective endocarditis, or certain congenital heart diseases. Okay, for follow-up, we have to monitor fever resolution, repeat blood culture, and renal function, and drug toxicity, and echocardiography, and valve function. Okay, so in high-yield exam points, what are the things we discussed? I'm going to tell some high yield important points for infective endocarditis. So in infective endocarditis, the main thing we have to focus on, the most common causative organism will be like Staphylococcus aureus. Intravenous drug users like tricuspid valve infective endocarditis, and you can see subacute infective endocarditis like viridans, streptococci. The most important investigation we can see like blood cultures, and the imaging we can see tracheoesophageal echocardiography is more sensitive than trans tracheo echocardiography. The classic painless lesions we call, that is Janeway lesion. Painful lesion will be like ossular nodes. The treatment duration usually like 4 to 6 weeks, intravenous antibiotics. Okay, so how to treat that patient when patient admitting in emergency department? If you suspect infective endocarditis based on Duke's criteria, we have to do blood culture and multiple that investigation serology test. Then after we have to start empirical intravenous antibiotics. Then after we have to identify organism. Then after we have to target antibiotic therapy like 4 to 6 weeks. Then after we have to assess complications like heart failure, abscess, persistent infection, and surgical evaluation. Okay, so mostly I covered everything about infective endocarditis. If this video is helping you, you can like, share, and subscribe. If you have any doubt, you can message me through Telegram, MedSteps Telegram channel, and Dr. Anandjana in Instagram channel, or in YouTube you can comment. So based on that, I will give reply. Okay, so next we are going to discuss the other topic will be like acute coronary syndrome in upcoming videos in episode 5. Okay, so I'm signing off. Myself, I'm Dr. Anand, final year medical student. Till the time, if our next video